join our presentation. As Benedict has introduced me, I am Dr. Nguke Makatundu, the Executive Director of Thamini Uhai. Thamini Uhai is a local non-governmental organization in Tanzania that has been supporting the government to reduce maternal newborn mortality since 2008. The organization headquarters is based in Dar es Salaam, and our program work has been based in 4 regions in the country, two of the regions in Western Tanzania and 2 of them in Eastern Tanzania. So I'm going to present today, as noted, the title, as you see, is the Lessons from Thamini Uhai's Birth Companionship Program in Western Tanzania. And I'm going to present about lessons learned, but I'll begin with discussing about the rationale of the program, the objectives, and also I'll provide some information on the program itself in terms of the partners, the phases of the program, and then the project details, and then we'll discuss the challenges and the results of the program, and what we learned after the implementation of the program. So the Birth Companionship pilot program that we had was a pilot project. And this pilot project is a project that was approved through ethical approval by the National Institute for Medical Research. And it was implemented in 9 health facilities in a region called Kigoma, which is in Western Tanzania. The project period was from July 2016 to December 2018. Kigoma region is a region that is mostly rural, with a population of approximately 2.4 million and estimated 92,000 births per year. The region historically has lagged behind other regions in the country in terms of maternal reproductive neonatal health indicators, because it had a limited availability of good quality services due to the fewer number of facilities, but also facilities that are not in good shape, and also had a severe shortage of skilled health professionals. Thamini Uhai started working in this region from 2008, support the emergence of obstetric newborn care in the region because of the high number of maternal deaths. And this birth companionship project was part of the larger emergence of obstetric newborn care program that was implemented in Kigoma region. And Thamini Uhai was also working with other partners, other organizations in Kigoma in implementation of that program. So about the rationale now of why we did the birth companionship program is as we continued working on the program of improving emergence and obstetric newborn care, one of the things that we noted is important to look at was how do women experience care? Do they find this care they're given is good quality care? Are they satisfied with the services? And how can we support them? Because we dealt more on the supply side, looking at the facilities, how they're equipped, the providers being trained. But there was another side that we felt was important, the woman side or the demand side to look at. And as time went on, we came to see that it was important to look at that side. And at the time when we started thinking of what to do, we came to decide that because birth companionship has shown to improve the experience of care and also outcomes of delivery, it was a program we felt it was good to do. And also during the time we're thinking of doing it, also WHO came up with some recommendations, such as the intrapartum care for positive childbirth experience and standards for improving the quality of maternal newborn care in health facilities, which showed that birth companionship was an important intervention to improve the experience of care, but also the outcome of care for the women during delivery. And birth companionship in Tanzania had not systematically been applied in the public health system. It has only been practiced in selected number of private facilities, which are more in urban settings. So we thought that having examples of basic companionship being implemented in government facilities in a rural setting will help the government and its providers to understand its visibility, acceptability, and the impact and the cost of the government health system, and also learn how to implement such a practice at scale nationwide. So in this case, due to the things that we are seeing in our facilities, but also due to the benefit we saw in nationwide, we felt it is important to implement this program, and that's when we started working on implementing the program. And the objectives of the program was to introduce companionship in non-health facilities, and also assess whether it's feasible, acceptable in rural areas, and also leads to increased utilization of facilities for childbirth, and if it improves the quality of maternal health services. We also, another objective was to monitor the implementation, because it was a new thing in Tanzania. It was the first such kind of a program in Tanzania, was to monitor the implementation and collect important lessons as we move on, and explore the potential of replication in other regions in the country. Partners of the project in implementation included Vital Strategies, which is based in New York City, United States of America. But also in monitoring and evaluation, we had United States Centers for Disease Control and Prevention, the Division of Reproductive Health, and Averting Maternal Death and Disability Program at Columbia University. And our project donors were Blue Lantern Foundation, Foundation HNB Group. These are based in Switzerland, foundations based in Switzerland, and the Bloomberg Philanthropies, which is based in the United States of America. The project was implemented in several phases. First, we started with the formative research, and then we started in the beginning, first 6 months, and then we started preparation and advocacy. Preparation, the advocacy was preparation in terms of working with the government, how do we implement this project, and also getting the ethical approvals to implement the project, and also sorting out some challenges and concerns that were there, which I will describe later. Then we had the Code of Good Practice development for the program, and we did the project implementation, and we had monitoring evaluation, which was done through facility data from the facility registers, implementation research, which was done by Averting Maternal Disability and Deaths, or MDD, and also other surveys like provider survey, client survey, and pregnancy outcome monitoring, which were done by CDC. These were major phases of the project. And in implementation, we had 2 types of base companions. The first type of base companion we called them desired base companions. And these were companions that were selected by a woman, a pregnant woman, who could be a family member, a friend, or a relative, and they come with them from home. And these are oriented during the antenatal care clinics visits, and in communities by community health workers, and also at the time of delivery. Another type of base companions were on-call base companions, and these were based in the facilities. They were selected by the communities, but they were based in facilities, and they were given a special orientation and training by Thamini Uhai. And these were available for the women to choose as an option if they don't have a desired base companion, but they like to have a companion during delivery. They can choose this base companion at the facility, and then the companion helps them throughout the process of labor and delivery. These base companions were supervised by the labor ward in charges in the facility. Some of the important activities, and I'll mention key important activities that were the project during project implementation. The first one I can say is that we had to improve the facility environment to ensure best companionship is possible to be implemented there. So we improve the facilities environment. I'll describe that later again, of these facilities, 9 facilities. And in implementation of the program in Kigoma, we had 15 facilities that were supporting to provide the comprehensive emergency obstetric and newborn care. So 9 of these facilities were implementing the project, but other 6 facilities did not implement this project. So we use these other facilities as comparison facilities So these were not, the environment of these facilities were not improved at the time. Other things that we did was to orient the health providers on the code of good practice after it was ready. And then we trained the on-call based companions on the code of good practice and give them working tools. And we facilitated trainings on how to give comfort to the women do delivery to the on-call based companions, but also to the maternity ward in charges. We also oriented non-community health workers on on best companionship and how to give information to women in communities on best companionship. We also conducted community sensitizations with community leaders. We did public rallies with community members and implemented a multimedia campaign where we had radio spots on best companionship, we had posters on best companionship, and also the community health workers on continuing giving information to the communities at the time. In implementation, we conducted monthly supervision to on-call based companions, learning the challenges they face, and then guiding them to improve, and also looking at the relationships they had with the labor ward in charges and sorting out any challenges that were there. We also continually oriented the desired-based companions in the antenatal care clinics, but also in the communities. We also conducted review meetings where these were special meetings where we sit down with them after some time, like quarterly, with both the on-call based companions, community health workers, and sort out the challenges that were there as a group and improve each other, doing cross-learning among themselves. And we conducted media stakeholder meetings that were chaired by a regional medical officer to review the progress and develop new action plans. We also supported 3 rounds of implementation research that were done by AMDD and used the findings to improve the performances. So those are the major key areas I can say on implementation. Some of the things I'll cover when I discuss about the challenges. So when we wanted to implement the program, some of the major challenges that we faced, especially it was during the formative research, when the formative research was done, but also as after formative research, when we were disseminating that research results to the communities, but also to the government. The concerns that were there were mainly from the women, were concerns of privacy, and also if there'll be confidentiality from the best companions, or if the best companions supporting these women during the time of birth, giving birth. This was a major concern from the women, and also from the Ministry of Health, the regional health management team, and the providers, the facilities. They were very concerned about the infection prevention because new people will be coming into these facilities. Also, they were concerned about confidentiality in the private and space. So how did we mitigate these challenges? We had meetings with the ministry and the regional health management team and the providers, and explained benefits of best companionship and sort out the challenges. We had several meetings with them, sorting out the challenges, listening to them, and then coming with action plans. How can we adapt our design to sort out those challenges? And then together with them, we developed a code of good practice that defined the roles and responsibilities and limitations of companions, but also how the relationships between companions and health providers will be in the facilities. So this helped in giving them ownership, but also incorporating all those concerns they had, what solutions were given towards those concerns. Then we constructed partitions in the maternity wards because that was a major concern on the private and the confidentiality. We improved the infection prevention controls in maternity wards through additional hand washing stations and also uniforms for providers. And also the uniforms were done also for on-call based companions and some desired-based companions if they needed some uniforms, if they could not have maybe the covers, clothes that cover them very well, or it was felt that they're not as clean as they should be when they're coming to the maternity wards. To ensure confidentiality for the women, we advise them during when they are choosing best companions to choose the people they trust from the communities to be their companion. It could be their mother-in-law, their friends. Ensure that choosing people really can give them confidentiality when they go back to the communities. And in case they do not have, then we have the option of them choosing the on-call-based companions in the facilities. That's how we mitigated the challenges. In terms of results, we had, I mentioned about this, we had Thamini Uhai data that was from the registers in the facilities. And then we had 3 implementation researchers. And then we had CDC studies, the exit interviews, provider interviews, pregnancy outcome, which were done in 2018. The CDC data is currently in final stages. I'll share some of the high-level results, but currently the data is in final stages of clearance, so cannot be used for citation distribution for now. But we'll share these results, the major results, but then cannot be used for citation, just for your note. In the CDC, when they did the evaluation, they used 9 facilities as intervention facilities. In 6 other facilities, as mentioned, 15 facilities, use them as comparison facilities. In the results, major results were that over 80% of women delivering intervention facilities had best companions during giving birth. And they reported that best companions gave them different types of support, like give them advice and instructions, comforting them, providing encouragement to them, reducing their worries, give them some fruits to drink, and staying by their side majority of the time. Majority of women interviewed at intervention facilities were very satisfied with having best companions during childbirth. Women in sites with best companions were more likely to report that they were very satisfied with the care that they received, that the staff were very kind to them and very encouraging to them. Most women intervention sites also reported that the presence of companion improved their labor delivery and postpartum experience. Most of providers found the companions were very helpful, and they felt they helped them in providing emotional support and comfort to women during birth. And when comparing intervention comparison sites, providers at the intervention sites were significantly likely to respond to women who called for help, and to interact in a friendly way, to greet them respectfully and try to make them more comfortable. In terms of deliveries increase, there are not much intervention facilities, it was only 2%. And at the same time, there was a 6% decrease in the comparison sites. These changes were not statistically significant. The maternal and perinatal mortality declined in both the intervention and the comparison sites. And while the declines were generally larger in the intervention sites than the comparison sites, the changes from the pre-intervention to intervention period were not statistically significant in either group of facilities. What did we learn? What we learned were that the introduction of best companionship in rural areas is feasible and well accepted by health providers, the government officials, and also the women. And by providing continuous emotional, information, and practical support, these companions improved women's childbirth experience and improved the environment of maternity wards overall. And so due to this, we saw best companionship can be institutionalized in the country. We also learned that it was important and valuable to create a set of guidelines in a participatory manner with all key stakeholders, as this helped us when we developed the code of good practice. It helped us to get, for example, all the ideas from different people, but also smooth time during implementation because of all people owned that program. We also learned that for effective and smooth implementation, it was important to closely involve providers, community members, government officials, both at the design stage and implementation stage, because when you involve them from the design stage, you incorporate all the ideas, and this ensures that they own this program and cooperate very well during the implementation phase. The introduction of best companionship required extensive outreach and using multiple communication strategies which are implemented frequently to ensure that AIDS providers, communities understood the intervention and its benefits. We also learned that incorporating implementation research to the project design is very valuable, as it allows the project to adapt quickly to challenges, but also share successful strategies across various sites. Having base companions coming from home is more sustainable. However, for a new program, having base companions based at facilities was very helpful while introducing the practice, because in the beginning, there's hesitation, and also you might find some women they would like to have a base companion, but they did not come with them from home. So it was very good to introduce this. And when they gain this experience, they can go to communities and tell them about their experience. And the word of mouth spreads in the communities. And as time goes, you find more women coming companions with the facilities. So this is all I would like to share with you. Thank you very much for listening. This is the end of the presentation. Thank you very much.
Dr. Nguke, thank you so much for these very strong lessons at the end, summarizing the process of getting where this project is now and how it actually evolved and scaled up. I'm going to give the floor straight away to Fran before we have our question and answer session. Please, participants, type your questions for the speakers in the chat box, and I'm collecting them, and I will read them out when Fran has finished the presentation. Fran, over to you. Can you share your presentation?
Great.
Yes.
You go right to the top.
You just do full screen now, and you are unmuted.
There you go.
There you go.
How's that, Benny?
Perfect.
So, oopsie, I'm not on the first slide, Benny. How do I get back? Let me
Go back to PowerPoint. Yeah, to PowerPoint.
Yeah. So I'm sorry, I had meant to get that on the first slide first.
No problem.
So, there we go. So, I thought that was absolutely fantastic and great work and really interesting and applicable to so many contexts. So, my name is Fran, and I'm the midwifery person in the WHO headquarters, working with many countries on trying to ensure good quality of care. And today, I know I have other members of my team on the call. So I want to also apologize for some awful banging that seems to be going on the roof just above my head. I can't do anything about that, sorry. I'll just go through. And what we're particularly looking at now is obviously with this COVID-19 pandemic and what the implications are on that for quality of care and companion at birth. So I'm taking many of these slides. I've just selected a few and adapted some from what is about to be released as a WHO training app on caring for women who are COVID-19 positive, which we will get out to all of you as soon as possible. So first of all, I think there are three main points to make.
Right, apology. People are asking if you can speak a bit louder because
I'm sorry about the banging. I can't talk to you about that. So first of all, there is no evidence that pregnant women present with different signs or symptoms, or that they're at risk of severe illness, and there is little evidence for mother-to-child transmission. And this is really important in that we're saying still that childbirth is as it always was, but of course if they are very sick, they're going to need additional care, but we should not change the routine high quality of care that all women should have. Pregnant women with suspected, probable, or confirmed COVID-19, even if they're in isolation, should continue to access women-centered, respectful, skilled care while applying necessary infection and control measures. Now, I've highlighted that in yellow throughout the presentation because that is really the big difference as to whether or not you have a companion at birth or not. This, having the infection prevention and control, will be absolutely critical. So regardless of COVID-19 status, mothers and infants should remain together, breastfeed, practice skin-to-skin contact, kangaroo mother care, and rooming in day and night while applying those very necessary infection prevention and control measures. I've added to this presentation that efforts to ensure a woman has a companion at birth should continue so long as IPC guidance is followed. And I think Dr. Nguki raised many important issues, including orientating their companion at birth and making sure the labour in charge is absolutely on top of the infection prevention to make this a safe approach. Sorry. So at the moment, the key messages are that there's no evidence that pregnant and postpartum women with COVID-19 infection present with any different signs or symptoms are at high risk of severe illness. So there is no clear evidence of mother-to-child transmission. Pregnant women with suspected, probable, or confirmed COVID-19, even if in isolation, should continue to have access to that care. So in this slide, it shows really that during labour and childbirth, care of pregnant women depends on the severity of the disease. And I don't know, Benny, can you move the in the top right-hand corner? I can see better now. Sorry, the actual WebEx thing. So this is actually in the training module, and it states very clearly that a companion of their choice during childbirth with these appropriate infection prevention and control measures, including training on the use of PPE and movement restriction in the healthcare facility, also raised in the previous presentation, is seriously important. They must still have pain relief, they should still be able to move around, and they should still be able to have midwife-led continuity of care in settings with well-functioning midwifery programs. And you can see the infographic on the right, and please feel free to use that wherever you are, and the references are all at the bottom of that slide. Sorry, I'm just trying to move down to my next slide. Yeah, I've got stuck. It's not letting me move to my next slide.
Go back to your PowerPoint application.
Very weird. I'm just.
Yeah, it worked.
So, for when you're caring for women during pregnancy, childbirth, and postnatal, as always, they should be treated with dignity, privacy, confidentially, freedom from harm and mistreatment, and enabling an informed choice. It's just not working. I don't know why. They should benefit from multidisciplinary teamwork from midwifery, obstetric, perinatal, neonatal, and intensive care specialists. They should have access to facilities with readiness to care for complications, and they should benefit from mental and health and psychosocial support. And I think that's an important point when it comes to the companion at birth, with prevention and management services for common mental disorders. They should be available. So it's just to reiterate, they should still have that good quality, women-centered, respectful, skilled care. Now, specifically, during the COVID pandemic, these maternal and newborn services are essential services that should continue throughout the pandemic. And we are finding in some countries that they are holding back on some of these services to focus on COVID, and that isn't recommended. We must continue with our essential maternal and newborn services. Childbirth care specifically should be prioritised within facilities, and many times there are examples of where childbirth facilities have been closed down to focus on COVID, and that is leading to enormous problems and great risks of increase of maternal and newborn mortality and morbidity. So any maternal and newborn health services provided in the facility should focus on promoting care seeking in communities, addressing risks of COVID-19 transmission through this infection prevention and control, and supporting home care practices. And access to services, as we know, may become difficult due to lockdowns. There may be less transport or fear of infection in facilities, or becoming infected in the facility as a woman or as a companion. And we must not forget that women and adolescents may have even less access due to gender issues, discrimination, and stigma. But let's remember that midwives and community health workers can together continue to support women. If they can't see them face-to-face, one-to-one, they can have regular phone calls or text messages or online communication platforms to provide reassurance and listen to women's needs, especially if she's got a problem and she knows she needs to come in. And I think that is where a companion can be really helpful. If the woman doesn't have a phone, she might be able to speak to the chief or somebody who does, just to make sure that we continue with this all-important communication. So for birth preparedness and complications readiness during the COVID-19 pandemic, obviously we must make sure that the woman and her midwife or whoever the care provider is should really continue to review that birth preparedness and complications readiness plan at every AMC contact. And again, if they can see each other face to face, that's fine. If they can't, they can continue to do that either by phone or text or whatever. Where there are changes to access to services, the women and their care team will need to replan. So they may not go to the place they thought they were going to, they may have to go somewhere else. And there must be a plan to inform women and say, well, how do you get to this other place? Or what is your phone number? And we must remember that transport and costs of transport may be different. You know, many places now there are very few buses, no trains, and you know, it's very difficult to go driving unless you have a real reason, as this would be. And the person who is selected to be the companion, and it's very interesting to see those two different ways in the presentation. They really must not have any signs or symptoms of COVID-19. That's really important. And the companion will have to be carefully instructed and follow those infection and prevention and control measures at the facility. So again, this orientation during the antenatal care mentioned in Tanzania would be so important. And health workers must really work hard to address any fear that women, their companions and communities feel about becoming infected in the facility. It's a very real fear. And so I think my last slide really is just about establishing infection prevention and control strategies. And we do have a lot of guidance on that. I didn't want to put it all up from the WHO website. But the most important things are ensure that all patients cover their nose and mouth with a tissue or elbow when coughing or sneezing. And you will have heard over and over again, wash your hands. Either with an alcohol-based hand rub, and we know quite a few clinics don't always have the clean water supplies that they want. So making sure preparing in advance that alcohol-based hand rub is there, and of course with soap and water. And I think I just wanted to make one last point, that breastfeeding really needs to continue. We've had some people have been putting out information there that says to stop breastfeeding. This is wrong. You must really continue breastfeeding wherever a mother can. But as usual, the mother must wash her hands before and after breastfeeding the child. She herself must practice good respiratory hygiene, and we suggest wearing a medical mask where possible when she's breastfeeding, and again, coughing or sneezing into a tissue and disposing of it immediately, and routinely cleaning and disinfecting surfaces that have been touched. So the companion at birth, keeping it going with good infection prevention and control, keeping everything as usual, and making sure the breastfeeding continues, unless they have those very strong signs of COVID-19, in which case, of course, you will need to bring in the medical team. But I hope that's helpful, just so that we continue with really good quality, respectful, skilled care throughout, and the companion at birth remaining to have that important role. Thanks very much.
Thank you very much, Fan. Thank you so much. We have quite a number of questions for both you and Dr. Nguke, and a lot of people asking if we are going to share the presentation. Yes, we are. It will be on the website, and we will send you a link with the recording and the presentation. I will read out the question that you got while you presented. There's a few questions from Rationale on how, what kind of birth companions they were, if they were the doulas, the one that were hospital-based. How long was training on ANC, labor, and PNC support, and were they paid? Dr. Nguke.
Hello, yes. So we did the orientation for about 3 days. For these ones who were based in the facilities. And the orientation was based on the code of good practice that was developed. And mainly because the companions were not doing the clinical duties, but they were just helping the providers, the facilities. There were a lot of things that they can do and those that they can't do. So we talked them through that. And then other things they were continually being oriented as time went on when they are at the facility. The training was covered by the donors of the project. But it was mostly a stipend for the 3 days that we oriented them.
Thank you. We have a question from Ray Stevenson about scale up and how this could be part of the government's approach. And I think what you didn't hear today is that part, the Ministry of Health perspective, because our speaker couldn't join today. But I think, Dr. Nguke, maybe you could talk about how the lessons from the initiative inform the national policy on excellence of care. Ras Stevenson asked how you plan to expand the learning nationally and to help the government approach and uptake of these important lessons.
Okay, thank you very much for the question. So as we continued with the implementation of this project, we're discussing with the ministry on how to institutionalize it first and how it can be scaled up in the country because of the achievements that we are seeing. And also, luckily, at the time we were doing this, also we're discussing with one of our donors, HNB Group Foundation, on how they can assist us to institutionalize this. So the government was very accepting of the practice, and even from, despite the fact that we had not had final results, which now we are getting into, as I presented from CDC, but the government was very comfortable with how things were going because they are monitoring the situation and see how it was benefiting the women. So in that case, the government decided to include this in national policy, and we worked with other stakeholders on gender and respectful care to form a guideline on gender and respectful care. And this work was done in 2019. And by November 2019, this gender and respectful care guidelines came out, and basic companionship was included as part of the gender respectful care guidelines. And also the code of good practice that we developed in Kigoma was included as one of the annexes as the best practice of how basic companionship can be done. So what is at the state now is that basic companionship is already allowed in the public health system, which is a major success. And what comes next is how it is going to be scaled up in the country. So in terms of scaling up in the country, the government will work with different stakeholders who will do the scale up in the different zones. But for Thamini Uhai, you already started scaling up from Kigoma. Now we are scaling up the practice in a region called Katavi, which is also in Western Tanzania. And we plan also to scale up at the regional level, the regional health management team, not at the facilities level, to other regions, Tabora and Geita. So our scaling up will be to 3 regions, but the government is also talking to other stakeholders who can scale up in other places. And also for ourselves, we are developing businesses. We are writing proposals which we're hopeful that we can also be involved in scaling up in other regions that where we are planning as of now.
Thank you. We have a question for Fran now on a presentation from Meron Tesema Bekele, asking if we should think about ensuring informed consent for mother infected with COVID-19 to decide whether the baby waits with a caregiver until she gets better and be fed with express breast milk.
Sorry, Benny, it's about informed consent and breastfeeding?
No, informed consent from mothers who are infected with the coronavirus on having the baby with a caregiver at birth and until the mother gets better and be fed with express breast milk instead of being with the mother.
So the question is, if the mother can't breastfeed herself?
If the mother has COVID-19,
yes.
Should we think about requesting the mother to give an express consent to have a baby cared for by a caregiver until she feels better?
Oh, and fed by a caregiver.
And that she will express breast milk to feed the baby, but not be in contact with the baby.
So yes, we have a whole set of slides. In fact, in the training app, it goes into much more detail on that. But if the mother is well enough to feed herself, to feed the baby herself, then she should continue to feed the baby herself. But it's a very good question, because if the mother is ill, then yes, the mother can breastfeed, and somebody else, her companion or her family, or whoever she chooses, could feed the baby for her until she feels strong enough herself to feed the baby again.
Okay.
Whether or not the informed consent is needed, I don't know if others from WHO or the call would like to add to that. But I would imagine the woman would want somebody, who she knows to care for her baby, or else it would be a health worker in a facility if she's very sick and would want the baby in the facility, so at least that she can have the express breast milk. It's a good point.
Thank you. We also have a question from Dr. Kera in India, asking what are the suggested testing strategy for pregnant women reporting for delivery. And this is a question that actually is asked in the labor room to ensure their safety.
That's another very good question. And to be honest, I don't have the answer to that, Dr. Kera. I know that testing is very restricted in many countries at the moment, and different countries are taking different processes. But again, I wonder if Annie or Blair on the call would like to say anything to that, but we will certainly come back to you on that.
Okay, I'm asking. Right, sorry about that. Annie or Blair, do you want to add to this? If not,
can you hear me?
We can hear you, Annie.
Yeah, it's Lerta. Thank you. Thank you. We are currently working on the guidance for the maternal newborn health programs service delivery during COVID. For testing for pregnancy, we are following the overall testing guidelines for WHO. Therefore, only those people who had exposure had signs exposure, so based on screening, they would be tested to confirm the diagnosis. So if for women or pregnant women, do we have additional or new guidance? As of right now, no. But going forward, that would be something that we'll need to look. There is no reason to believe that pregnant women are at a higher risk than the general population. There is no, as Fran already shared the information, there is no indication of mother-to-child transmission. So those are some very important aspects which are relevant for the childbirth. So we are putting that full IPC should be in place for the health workers who are assisting during the childbirth for positive or non-positive mothers. At the same time, that does not mean that the routine services shouldn't be provided at the same level and quality. Over.
Thank you. We also have another question, again from Dr. Kira, a comment rather than a question, mentioning a place where the delivery load is very high. It's very hard to practice birth companionship approach. Do you want to talk to that, Dr. Nguke?
Sorry, can you repeat the question?
A comment on how difficult it is to actually have birth companion in a facility where the delivery load is very high.
I can say the challenge is there if the deliveries are very high, but what we found in the project was that actually the health providers saw that the birth companions reduce the workload that they have, especially in this setting. So for what the way I could answer that is if that setting has enough delivery rooms, like enough delivery space where a birth companion can be there, especially the desired birth companion who is coming from home, then it should not be a big problem on having in a busy facility. The challenge comes if there are no birth companion from home, for example, and you have many deliveries, and many of the women giving delivery, they would like to have a companion, so they have to have the on-call birth companion. So the on-call birth companion, for example, cannot give companionship to two women at once. That's where the challenge comes. But if the birth companions are coming from home, and if you have enough delivery rooms, it should not be a challenge. Mm-hmm. It should be something that is helpful to providers, because the role of the companion is to help the mother, but also help those duties that are non-clinical of the provider. So the provider would really be able to concentrate on the clinical work and provide better care.
Thank you. We have two questions from Isi Haka Jose. Sorry if I mispronounce your name. on what motivated women to choose either a birth companionship on call in the facility rather than one from the community, and then whether staffing level were an issue during the delivery and how you did navigate that.
Can you repeat the second part?
The second part is whether staffing level was an issue during delivery and how you managed to navigate this issue, if it was one.
Okay, so what motivated them to whether to come from home? I think the issue was, as I mentioned, the challenges. It was the issue more of whom they trust from the community to come with the facility and whether that person is available. So as time went on, as time went on, we saw more women coming with the birth companions from the communities. But I think in the beginning, maybe they were not very comfortable in coming someone to be a companion. So they depended more on the companions from facilities. As maybe after that practice became a common practice, then they were able to really feel more women in the communities felt that they could bring someone at the facility. I can mention it that way. I cannot say that which one was the better method. The better method we are thinking would be the one coming from home than the facility. But in the beginning, there was a hesitance of coming with them from home. I think because they would feel maybe this is something that is technical and needs someone who has experience. But once the women had more companionship at the facility and the giving word of mouth in the communities, we saw the number of now those coming from the communities coming up. In terms of staffing, most of facilities in Kigoma had their staffing challenges even before companionship was there. So when birth companionship came, it actually reduced the workload of these providers. And we did birth companionship the good thing, we did birth companionship in the facilities that were able to accommodate more than one birth at a time. So even if there was one provider to support women, we were able to have like 4 rooms, different rooms. So if there are 4 women or 3 women giving birth, all of them have a birth companion. And this helped this one provider. If she's able to take care of all these women at once. And if there's a problem in one of the rooms, then that companion would call the providers to go and help. So for me, for the experience that was there before companionship, where already there was understaffing and we were having a lot of challenges giving support to delivering women. When birth companionship came, that workload was reduced and they were able to serve them better. And you could even see that the outcome of delivery, although they were not statistically significant, but the outcomes of delivery both to the mother and newborn were better when birth companionship came in place.
Thank you. The question keeps coming, so I'm going to take 4 more. There's 2 questions regarding how the birth companions were working. First, a question from Caroline Curtis on whether they were paid, and the second from Stevenson on whether men were allowed to be birth companions.
Okay, the birth companions were paid stipend by Thamini Uhai. They're on-call birth companions. They were paid a stipend from Thamini Uhai, and but those who were coming from home, they were not paid anything because they were community members. So there's someone that delivering woman trusts. So they come to the facility, they get oriented during the antenatal care clinic, and they come twice to get that orientation. And after that, during the time of delivery, they come with a woman. So it could be a family member, a friend, could be a mother-in-law, could be a sister. So these are not paid, but those in the facilities were paid. Though for the scaling up, now when we went to another region, and after the learning we got from Kigoma, we introduced directly the desired birth companionship, the one that are not paid, because that was more sustainable. But for the beginning of the program, because it was a new thing in the country, it was important to us to have these ones whom we paid stipend, so that when the pilot come, we really have the results of the pilot in terms of really birth companionship taking place in the facilities. But in terms of for long term, the ones who are not paid are the ones that are more, I can say, more suitable. The men were not allowed in best companionship, and this was one of the main things that when we are seeking approval from the ministry and National Institute for Medical Research, this is one of the main things that they insisted that for the pilot, because they were not sure if the facilities were able to have the privacy and confidentiality to be able to bring in a man in the facility. So they said for that time, let's have only women coming in and let's ensure there's good privacy. So the men were not allowed during the pilot. And up to now also because of the situation of the facilities, we mostly use women, though in terms of guidelines, the gender certificate guidelines, it has not limited whether men and women should be there. So when the environment should not be there, so it has not said whether men should not be companions. So if a facility is able to bring men in, I believe it's possible now as we go to the future for them to bring men in, depending on the environment in that facility and depending how the leadership in that facility sees that is fitting.
Yeah. Thank you very much. We have another question for you, Francis, on whether what you mentioned about having the baby a newborn baby in the care of a carer if the mother is sick, whether that would be part of the WHO guidance.
Thanks very much. Good question. It is. I mean, there's a whole other PowerPoint and training app on breastfeeding, and it takes all the different aspects in it: the healthy baby, healthy mother, the healthy baby, not healthy mother, the small and very sick newborn baby, babies that need kangaroo mother care, or babies who go into special baby care units. So I think the best thing is that as soon as that app comes out, Benny, that we will share it, with obviously with the QOC network and make sure everybody has access to that. But it really does look in detail in all those different scenarios. They take a slightly different approach to the needs of the woman and the baby at that time.
And a very last question for you, Franz, and last question at all for everyone. Is there a recommendation, on immediate bathing of the baby when the mother is COVID suspected or confirmed?
Can you say that again?
Is there a recommendation on the immediate bathing of the baby when the mother is COVID-19 suspected or confirmed?
No, it just doesn't seem to be. Are you talking about bathing the baby?
Yes. Sorry.
Yeah,
yes.
Bathing the baby. No, the recommendation stands as they always are. So really nothing has changed. As much skin to skin as possible. Start the breastfeeding within an hour, and all the rest of it. So nothing has changed from those standard recommendations, other than if the woman is COVID positive and breastfeeding and with a small or sick baby.
Thank you very much. I think I got about all of the questions. There's one or two that were that you addressed answering other people. So I hope you got your answers. Thank you for your patience, everyone, and for our two speakers. The lot of content they shared today on the Thamini Uhai initiative and now.
Thank you
COVID-19
very much.
Yes, we're going to post this on the qualityofcarenetwork.org/webinars. I also have all your email because you registered, so I will send you the link with recordings and both presentations. And thank you very much for your time. Have a fantastic day. Thank you to our speakers. Bye.
Thanks all.
Thank you.
Thank you.
Thank you.